I can see how much audience participation I'm going to get based on that response, which is pretty little. Okay, can you hear me out there? Give me a wave. Okay. All right. Podium mic's on. Yeah, they're on? Okay. Podium mic's on. Okay, so this is a little talk I'm doing mostly on preoperative testing and this new thing that we have in Canada called Choosing Wisely that you guys may have participated in the last couple of years by filling out their survey that came, I think, probably about a year and a half ago. I remember filling it out. And I'm going to have a few plugs in here to come join me in the pre-admission clinic and help out with some of the projects down there. So there's some blatant plugs for pre-admission clinic help. All right, so first thing, my objectives, which were sent out to review Choosing Wisely. I'm looking at the Choosing Wisely and sort of comparing it to some of the other standard guidelines that we currently use for preoperative testing, and just see what's different between the two. To look at, and I'm going to ask for your help here, some of the ordering processes at RCH, and hopefully you guys can help me come up with some ideas for how we can improve things as far as pre-op testing and pre-op ordering in the pre-admission clinic. And just a question that I've had for years after being a resident at UBC and having this belief shoved down my throat that if you intubate anyone with rheumatoid arthritis that you haven't had a flexion extension view of their neck, you're going to cause quadriplegia, which is basically what we're sort of told, and sort of coming to question that in the last few years. So I just wanted to, it was more of a personal learning question. All right, so 3 forms of anesthesia: general anesthesia, local anesthesia, and lectures. Be the third type. All right, so we're starting with a little vignette. And so you're seeing Mrs. BP in the pre-admission clinic, and she's kind of a lowish risk patient for here. This might be at Eagle Ridge. She's going to have an elective laparoscopic cholecystectomy a week from now, which is pretty good if you're seeing her a week ahead. She's 62, she's slightly overweight, her BMI is 29. She has high blood pressure that's well controlled on hydrochlorothiazide and ramipril. She's hypothyroid, but well controlled on some Synthroid, and she has some dyslipidemia, and she's on a statin. She's got a good family doctor. She's pretty active and has no other medical comorbidities. So what preoperative test does this lady need? So just want you to think about that for a few seconds. If you have a neighbor, tell your neighbor what you think that they need and have a 2-second argument. All right. Okay, so just sort of have that in your head, and then I've got do any of these sort of go along with what you were talking about with your neighbor? So A, ECG, a chest X-ray, CBC lights, BN creatinine, INR, PTT, some liver function tests, TSH just in case, and an echo because she's got some cardiac risk factors. How about an ECG, everything except for the echo and the TSH, or maybe just an ECG and a CBC, or how about just the lights, BO, and creatinine, or maybe nothing. So those are, just think about your answer here and see what sort of goes along with it. We're going to come back to this later after a little review. All right, so Choosing Wisely Canada, what is this? So the CMA got together with the various specialty bodies, and in our case, that's the CAS, and looked at how we can decrease some of the expenses of the medical system. And one of the expenses, or a big part of expenses, is unnecessary testing. And that's in every area of medicine, us included. So a survey was sent out, and some of you probably remember filling the survey out. I certainly remember filling the survey out just because I'm anal and fill out all the surveys that come to me. And it was based initially on some work that was similar that was done by the American Society of Anesthesiologists. And they gave us a list of 12 tests and procedures and asked us some questions about each of those tests. And the questions revolved around things like how frequently do you order these? How much impact do you think those tests have on the quality of care that patients receive? What the cost is? is there any supporting evidence? And just so you know, there's very little supporting evidence about almost all preoperative testing. And then is there a potential to avoid ordering this? And then they had a committee that got together and did a statistical analysis of that survey and had some expert consensus and looked at the evidence as well. And they came up with a list of 5 top recommendations of tests that we should at least think about before ordering preoperatively. So they're not saying don't order them preoperatively. We're all independent clinicians and can do what we'd like. But just think about whether or not these patients need those tests, because quite often they probably don't. So the first one was baseline labs in asymptomatic patients undergoing low-risk non-cardiac surgery. So what they came up with was essentially most baseline labs don't really change your management, and they don't improve patient outcome. So if they're an asymptomatic patient coming for a fairly low-risk procedure, they probably don't need the labs done. Okay. So what does the CAS guidelines say? Because this is the other sort of guidelines that we have that come out every year about what we should be ordering. And they're a little bit more specific. So this is the 2016 CAS guidelines. For the most part, they agree. So most of these things are either major surgery or would be symptomatic patients where you would need this. So a CBC would be hopefully chronic symptomatic disease that you might need a CBC for. Suspected anemia, so again, a history is better than a test. If they're fatigued on exertion, if they look really pale, you might get a CBC. Bleeding diathesis, myelosuppression, and hopefully we're not seeing less than 1-year-olds. INR PTT, again, kind of makes sense. Anticoagulant therapy, bleeding diathesis. The one area that there's a little bit of difference is the electrolytes and creatinine. And hypertensive patients aren't necessarily symptomatic, and a lot of our hypertensive patients are on diuretics or on other treatments that could cause electrolyte disturbance. So this is a slight difference between choosing wisely and the CAS guidelines. And I think it's just up to us as clinicians when you're thinking about whether they need that test to use your clinical acumen and decide whether they need that test or not. I don't think just because the CAS guidelines say it's just that they need that test because they have hypertension, it doesn't necessarily mean that they do. You might look at their level of hypertension, whether it's controlled, and the dose of their medication. Richard?
Not say that they need this test.
They say you could order it.
They say consider these
Yes,
tests.
Exactly. Okay. And again, guidelines are only guidelines. Glucose, diabetes, again, beta HCG, any female could be pregnant, which is basically anyone between the ages of about 13 and 55, 60. What? If you count IVF and donor eggs,
they'll tell you. They'll know.
All right, and a sickle screen, this is probably more, we don't see a lot of sickle cell, but out east they do, so that's why that's in there. All right, so recommendation number 2, patients don't need a baseline ECG if they're asymptomatic and undergoing a low-risk procedure. And so I'm saying especially older patients because I see a lot of patients with ECGs and it's ordered because they're over 50. There's no age cutoff where someone needs an ECG. So if they're 65, 68, and they have no cardiac disease, they're asymptomatic, they're outside gardening, and they don't need an ECG. One of the reasons is that even though there's a higher frequency of abnormal ECGs as we get older, there's more PVCs and PACs and sort of borderline ST abnormalities, and that we all kind of look at them and go, eh. And it doesn't really change our management of those patients. They're always useful if you've got a patient who's symptomatic, if they've got chest pain or palpitations or shortness of breath. They're useful to help you come up with why they're short of breath, but not or if they've got coronary artery disease as a baseline to see if they've got changes after the surgery if you are worried. But in your low-risk patients who are low-risk surgery, doesn't matter their age, they don't need an ECG if they're not symptomatic. So the CAS guidelines, very similar. Basically, again, they say if they've got coronary disease, a baseline is probably useful, but in other patients they shouldn't be. The CS guidelines also add in a little bit about patients with subarachnoid hemorrhages, which is what I've got here, those lovely Canon T waves. And those aren't necessarily low-risk surgeries to begin with, though. Okay. So recommendation number 3, and I must say, in the pre-admission clinic here, I cancel about 2 to 3 chest x-rays every time I'm in pre-admission clinic, if I can catch them before they go. They all come with their little bright orange flag to go down to imaging, and I say, why are you getting a chest x-ray? Most of them have no idea, and they've got stable COPD or something, or just are a vascular patient for a venous stripping, and they're heading down to, and I take it away, and I just say, go home and cancel it. Okay, so most patients, there's very few patients who need a chest x-ray before surgery. Acute cardiopulmonary illness, so if they're hacking and coughing and you're wondering if they've got COPD exacerbation or pneumonia, sure, but even stable COPD, it doesn't change our management. Most of these patients have had a chest x-ray in the past, and you can see if they've got a huge bulle on one side or something in the past, but they don't need a chest x-ray every time they come for surgery. So CAS guidelines, again, very similar. If they've got active cardiac or pulmonary disease, sure. And maybe a workup for testicular cancer, which spreads to the lungs really quickly, that would be a reasonable thing. But most people, you can cancel those chest x-rays. They don't need them if you can get to them in time. All right, number 4, don't perform resting echo for asymptomatic patients undergoing low to intermediate risk non-cardiac surgery. So if you hear a rip-roaring murmur, of course, you're going to order an echo. If you're wondering why they're short of breath on exertion and you're wondering what their left ventricular function is, it might be a reasonable thing. But it's also not a useful test for if you're wondering if they are higher risk, they've got hypertension and diabetes, and you're wondering if they've got some perioperative cardiac disease and are at risk of an event. An echo is not a useful test. Most of the time it's going to be normal, and it's not going to change your management. The words low to intermediate risk surgery prompted me to kind of do a little search on, so what is high risk surgery? I know when I was a resident what the ACCHA guidelines defined low, intermediate, and high risk surgery was, but that was a while back, so I thought I'd review it. And when I go to the new AHA-ACC guidelines, that all has been taken out. So there's a lot of changes actually in the AHA-ACC guidelines from when I was a resident, and I found it really interesting. And actually, if anyone wants to do a round, a really interesting topic is the fact that they're using a lot of these cardiac risk indexes in the new guidelines as part of their, I don't know if you remember the old flow sheets. If it's low risk, if it's emergent, go to surgery and do what you can. If it's low risk, go to surgery, don't worry about it. If it's intermediate risk, look at their METs. If it's high risk, that was the old algorithm, and that is all changed on the new ACCHA guidelines. And there's a lot more emphasis on these cardiac risk scores. So whether it's the RCRI, which is the Lee's Revised Cardiac Risk Index, or the NISQIP Risk Index, there's a lot of emphasis actually on calculating these risk indexes on our patients going for intermediate to higher risk surgery on their algorithms. And I thought that would be an interesting rounds topic at some point in the future to go through what are the various risk indexes out there, and should we be using some of these risk indexes or calculating these risk factors for some of our higher risk vascular patients, or whether or not, again, that's a useful thing to do. Anyways, so they don't actually have any of those high, low, or immediate or moderate risk surgeries in the guidelines anymore, but they do use the RCRI now in their guidelines. So when you go to Lee's Revised Cardiac Risk Index, high risk surgery in their definition includes intrathoracic, intra-abdominal, and suprainguinal vascular surgery. So for the purposes here, we're just going to think of high risk surgery as those. If you want to look into some very specific definitions of high, low, and moderate risk surgery based on what you should include and not include, the modified Johns Hopkins surgical criteria is fascinating, but it is a topic in of itself. Anyways, it goes into a lot of detail about what you should include in your various risk analysis for the surgery. All right, so what does the AHA and the ACC guidelines say about echo? If you have a patient with shortness of breath of unknown origin and you're wondering what their LV function is, it's reasonable to get an echo. If they have a known LV dysfunction and any sort of a change in clinical status, it's reasonable to get an echo. If they have decreased ejection fraction and it's been a while since they've had an echo, it's reasonable to get one. And again, this is class 2A evidence, which shows none of this is based on randomized controlled trials. There's very little evidence for almost all preoperative testing out there. Valvular disease, so if you suspect valvular disease, if you've got a murmur that's radiating up and they've got some delay, if you're wondering if they have moderate valvular lesion, you should probably get an echo. If there's a change in their clinical status and they have a known valvular issue, you should probably get one. If it's been a while, again, similar things, kind of reasonable. So the last recommendation was don't perform cardiac stress tests for asymptomatic patients undergoing low to intermediate risk non-cardiac surgery. So again, not those high-risk cases that we were talking about before. And that is because basically we don't see complications on patients undergoing low-risk surgery who can perform more than 4 METs. So if they can go up 1 or 2 flights of stairs, if they can walk on the flat at 4 miles an hour, if they can do some heavy lifting and gardening around the house, don't get a stress test for these patients. It's a waste of money and time and everything else, okay? And the AHA, ACC guidelines agree with that. So if they have an increased risk, if you don't know their exercise capacity, if they have poor exercise capacity and they're going for those high-risk surgeries, those are the patients you're going to get a stress test in, probably, if it will change your management. And that's always the caveat. And often it will change our management in as much as we may look at higher acuity post-operative care. We may look at increasing our monitoring intraoperatively or post-operatively, or the medications we're going to have, or the type of anesthetic we're going to give. But this is certainly not necessary for lower risk surgery. All right, so back to Mrs. BP. Any change in what you would do for this patient? So there's no right answer to this question because we're all clinicians and you're going to look at the patient and you're going to look at how they look and what their blood pressure is. I'm hoping from this talk that everyone knows that A, B, and C you probably don't need. This patient doesn't need an ECG. She doesn't need a CBC. Hopefully they're not losing more than 500 mils of blood in a lap chole. Whether you're going to get the lipo and creatinine or do nothing would again depend on whether you're looking at the CAS guidelines or whether you're looking at choosing wisely. And there's no right or wrong answer here. You decide. The CAS guidelines might suggest that you get the lipo and creatinine because she has hypertension, she's on a diuretic, she's on some things that could change her electrolytes. Choosing wisely would probably say she's asymptomatic, it's low risk surgery, she doesn't need anything. And so try to the point is to try to minimize. Yeah. Not really. It's a low risk surgery in a patient who can exercise. It doesn't. Would you cancel her? Yeah. Well, and that's again where you're going to look at her symptoms. You're going to look at her dose of hydrochlorothiazide. A small dose of hydrochlorothiazide is unlikely to produce a potassium of 2.5. So again, that's where you can use your judgment. Kenneth. Yeah. So we're getting there. That's the next part here. That's a good segue, Kenneth. Okay. So that's great. No. Yeah. Culture. We're talking about culture. We're talking about culture.
We can't. People used to have, as there are now, INRs, PTTs on all their patients for inguinal hernias and stuff like that. And for several years, we weren't doing that. But then the surgeons start ticking off the boxes,
So
and they're the population.
So this is all great, but who actually orders the test?
Exactly.
Right? So we can educate ourselves, we can educate our pre-admission clinic staff, which I'm hoping to do on Monday. But who orders them here? The surgeons, or more likely, they're MOAs. And they're not educated about this. So how can we change this? And this is where I'm wanting some help from you. So I have a few ideas on different things, so there's no one right answer here. Does anyone have any ideas?
You can automatically cancel any chest X-ray request. I mean, it's too simple. I mean, you have to, or you can say hold any chest X-ray request until you say it's okay.
Okay.
Basically.
Yeah.
So as they come into the pre-admission clinic, chest X-rays are all held until they see us.
I'm a bit reluctant to cancel a test that some other physician.
No, no, just hold.
I think the surgeons are scared of our reaction, and then they're just like, oh, just now I.
Well, they're scared for good reason, because we are all not all on board. So they're scared of having their patients delayed or canceled when that patient who's gone through pre-admission clinic and one of us has said they don't need any tests, and then another one of us sees them on the day of and says, well, I won't go ahead until I get this test or that test. So part of the problem is that we aren't all on board with this. Kenneth?
Of all the chest X-rays and ECGs that surgeons order, how many of those chest X-rays and ECGs do the surgeons ever look at?
Oh,
That's my.
They
kind
don't
of-
That's not why they
That's
order it,
just
though.
what it says.
That's not why they order it. They
order
order
them
it so
to-
that we won't delay surgery by saying that they need it.
Yeah.
They don't.
Okay, but
It's like cancellation insurance.
Yeah.
Sure, but my counter argument is this, like, so
That's an excellent analogy.
at Christmas time, I was exposed to a patient with TB in pre-admission clinic,
cancellation.
which was later discovered on the chest X-ray that was
But you don't
ordered
pay for it.
and done
Usually
after I
by
had seen the
insurance, you
patient.
have to
So,
pay
you know,
insurance.
That's a very rare, I don't think we're going to order chest X-rays on all our patients.
No, I'm
Read
not
that
suggesting we do, I'm just
case.
saying nobody looks at them, right?
Yeah,
Yeah.
no, I mean, I think,
Looked at it, yeah.
or we could at least say, don't do the chest X-ray until we say, do the chest X-ray.
Well, the real thing Shelley is stressing towards is surgeons order no tests. We order them all.
Yeah.
Yeah.
That's what she's gonna
Yeah.
suggest next.
Yeah.
Well, I'm
Logistically,
suggesting
that's
we
more
think
difficult.
about that. There's obvious
Well,
issues with
That's what a
that.
Ramsey protocol is.
Because part of what we want to see when we're seeing these patients is that the testing that is done on higher risk patients or higher risk procedures can lead us in a direction for other tests that they need for, I think I sent 2 patients my last pack date for iron sucrose infusions. And it was because I saw a hemoglobin of 85, prior to surgery. So there's pros and cons to all of these different suggestions. One of the suggestions, yes, is that we order all the testing. Yeah.
Nobody's gonna like this suggestion, but it actually works. I would rather sit down sometime near the end of my pack day and look at the list for the next day and order the appropriate tests for those patients, and sit there and go through a list of, should we see this patient who has an anxiety disorder, or this patient who takes the number. I have pictures of files of where I've looked at something like 25 charts at Eagle Ridge for the 12 that I saw, and it's mostly an exercise in futility, but to actually sit down and say, okay, these are the cases tomorrow, if we trust each other, we can do it ahead of time so that when the patients show up, they do know if they're going to get an ECG and a chest X-ray. They don't have to wait for us and for us to be interrupted on a repeated basis during the actual day where we're seeing patients.
What do you guys
But I
think of
know
that
people won't
suggestion?
like that.
Too
So
radical, yeah.
the
Yeah.
problem with that is, that's great for when you can see what the surgical procedure is and maybe just base it off of that. But some of these recommendations depend on whether the patient's symptomatic and stuff like that.
Right.
The only way you're gonna know that is either when you see them,
Yeah.
or if you're gonna go through a detailed entire review of their chart,
Yeah.
essentially like you're gonna see them in
But if they
consult.
filled out the questionnaire
Yeah.
that's in everything, takes 2 seconds to go through the one page where they answer yes, no, yes, no, yes, no, yes, no. And it's got a medication list there too.
Notoriously inaccurate.
Do you not think
Yeah.
that with some guidelines that if you get the nurses screening them better pre, and the other thing I'm going to ask, are you guys currently accessing the lab link to the community where you can, often patients have had blood work?
We don't have the lab.
They're working on it.
They're working on it.
Oh, because, yeah.
We don't have it yet.
You can get there through Meditech.
Yeah, through Meditech now, there's a connection that you can
Yeah.
get their lab work.
And
So you
see
can get the
lab
unit
results
clerks
from-
actually have that function. I just pulled some stuff out of St. Paul's. You can get histories from all over now, all the different hospitals, and you can also do lab link.
Yeah.
So you could have labs, recent labs pulled and put on which would avoid lots of tests. Lots of people have had blood work going up towards their surgery.
So one of the things I'm going to be talking, this is a topic I'm talking about at my education day on Monday with pre-admission clinic nurses, and is to feel out their comfortability in doing some of that screening process and ordering. Right now, they actually have to ask us before they either cancel or order anything. They actually don't have any ability to order or cancel tests right now.
You're talking here, not Eagle Ridge, right?
Here, yeah.
Because Eagle Ridge, they're ordering stuff all the time.
I think that might just be a culture. I don't know that they actually have any ability
No, but they do-
legally
they do.
or within their guidelines to do that. But that just might be a cultural thing at Eagle. I know much less about what happens at Eagle Ridge than here. So that's one of the things I'll be talking with them about is what they're comfortable with. Of course, educating surgeons is going to be part of this, educating the MOAs. One of the problems with educating MOAs is there's a high degree of turnover.
Yeah.
So even in trying to educate them about the fasting guidelines, which I did a whole education session not that long ago with them, so that they would stop telling the patients to not eat or drink anything after midnight, half of those MOAs are gone 3 years later, and they're different MOAs now. So there's lots of issues with this, but Guy, that's an idea I hadn't thought about before, is looking at things ahead of the night before. I will be assessing out with the nurses how much they feel comfortable doing. The other thought outside the box is potentially having a nurse practitioner whose job it is to go through these charts, do that chart review, and look at their previous labs, that sort of thing, and look at what tests are needed. And I think you could make a very good business argument for the cost savings of less testing, paying for the salary of someone to do that, who could also probably do some other things in our pre-admission clinic as well.
And that's a model used in the States.
Yeah.
A lot of places they'll have a pre-admission.
I think that's a great idea.
Yeah.
My question to you would be,
It's a cool job.
in that business case, to Fraser Health,
Yes.
does Fraser Health actually pay for
No.
the blood testing being done?
No.
And they
We'll
get
be paying for
they
the
that's
get
the-
they make
yeah.
money on the labs, right?
So that
That's
is the
outpatient.
problem. It's always past the buck with finances.
It's a great-
Yes, Richard.
I guess the other question is how much to sweat over it. You know, in truth, the CBC and lights is a very cheap test, and ECG itself is.
Oh, sorry. As an Eagle Ridge, or as a comment from Eagle Ridge, how about the idea of it's fairly easy to educate surgeons on blood work, or somewhat easy, and also it does stimulate for, I can see it's nice in a perfect world to have the blood work when you see the patient, especially the needed blood work. Why don't we tell the surgeons that we will order chest x-rays or EKGs if we think they're needed. If they think there's a surgical reason to order either of those, then go ahead and order it. But otherwise, if it's for anesthesia purposes, we will look after that end. And then we educate them that you may not need the full panel of blood work on X patient.
Yeah.
Give them some guidelines.
Yeah, that's reasonable.
I mean, that's what I started to say, really. The blood tests themselves are relatively small potatoes, and ECG is truly a pretty small potato. Chest x-rays cost a little bit more. I mean, I don't think the whole business I wasn't happy with the outcome from choosing wisely, because, I mean, we can't even order an exercise stress test and have to go through a cardiologist. And I don't think we order echoes very randomly, so that was a waste of work. That translated over from the United States, where in the United States, I think these things are done much more widely. The whole choosing wisely thing started in the States, of course. So I don't know that we should sweat it too much, although Doug's comment is a fair comment, yeah.
Faisal, and then Steve.
So I like Doug's suggestion, and if you take that a step further with what Brenda was saying, it may make the whole process at the pre-admission clinic easier if the surgeons are ordering the blood work, appropriately educated blood work.
Yeah.
And they get their patients to do it in the community, and we link to it, and we have the blood work printed when they come, then we're not waiting for the patient to go to the lab.
Not waiting to them, we're not ordering an ECG, so we're not waiting for them to go to ECG.
And on a patient side, the time at the pre-admission clinic would be significantly less, which is a huge issue for them, especially here. The parking's a nightmare here.
Yeah.
And it's only gonna get
So
worse.
if we get the surgeons pre-educated on the blood work, and the patients get them done ahead of time, and we get them linked, whether we have access to it, whether the AIM system has access to it, whether the Unicler's printed out, whatever it is, it's there, it makes the day shorter for patients, makes it more efficient for us.
So they're coming in essentially to see the nurse and us.
And the other thing now, I don't know if you guys know, you can link, as I said, to discharge histories, et cetera, from all other hospitals in the Lower Mainland, so to and the island as well. So you can go in and patients that have had a visit at St. Paul's, you can go in and get their history discharge from that visit.
I think you're a little optimistic about it. It's not that perfect system, Brenda.
No, I just did it yesterday. It was great.
Building on Brenda and Richard's comment, I think it is a burden on the patient, even if it's a small test, this is not a big test or expensive test. Patients are having to trudge from their home with their cardiac disease or liver disease or cancer, come in for their testing, and then go home. Or they come in twice to our clinic now, I guess, to get some testing done, then they come back for just to see us. So I think it is hours of time for someone to spend unnecessarily, so we should be careful in testing that we do order, even if it's just a cheap test. And the point about the one way around this, could we not just come up with a standardized form that you just put the patient's name in, that we saw patient X or Susie Q today in the clinic, and based on current guidelines and the Department of Anesthesia's clinical opinion, they don't need the following test results, and just have our unit clerks fax it to their unit clerks, and a handful of times a day that happens, and then over a month or two when they start getting a stack of these, they'll figure it out. It's sinking in.
Back to the surgeon's office, you mean?
Yeah, back to the surgeon's office.
So if we cancel the
It'd
chest
take
X-ray,
2 minutes to do.
rather than just cancel it, I should
Don't cancel, yeah, just
send it back,
just send
send a note
a
back
little
to them.
nice note back saying, in the future, we don't think it's
Don't you
necessary.
think they'll ignore it, Sue?
The first 10 or 20, 100 or 200.
Because if it doesn't affect what they're doing, they're gonna staff them, right?
You might clog their fax machine.
But it affects the MOE though.
What, Cedric, and then I've got one
Yeah,
more,
I mean,
one more little topic here.
I also cancel lots of tests, but one of the few tests I commonly do add on is if I do see a low hemoglobin and I want to do some sort of iron therapy. So I think that one of the issues is if you do have people do pre-op testing at some outside location, we don't then have the ability to add on a test, I think, within our lab. Now, I think the way to go around that is that we do eventually, hopefully, have some mechanism to deal with like a blood hemoglobin enhancement program. Hopefully there will be some additional screening of those patients, maybe 24 or 48 hours before they come, and then those people can be flagged, and maybe they can then go to our lab to do the additional testing, asked to come in an extra 20 minutes early or something like that. So I think there's a mechanism around that, but that's just one of the few things I see as an issue with this.
Something to work together with our blood utilization program.
I just want to speak very strongly against the concept of having people go to outside labs and get tests, because I want all my labs in one interface. It's true from within Meditech you can go to yet another step or 2 steps or 3 steps and find a hemoglobin PC bio. I don't want that. In fact, if somebody suggests that they go somewhere else to have a blood test done, I think it should be within the hospital.
What if that same blood work can be imported into our AIMS, which is supposed to come up?
Well, in the fullest time, once we get to a truly integrated EMR, but we don't have that yet. So until we have that, now I'm not saying that having the blood work done earlier, although it's 6 months wait for some patients, so when would you have them have their blood work?
A quick comment then. In that case, then why don't we say that they can have their blood work done, but only at Royal Columbian, Eagle Ridge, Langley, Peace Arch, any of the Fraser Health sites. They can go to any of those labs and do it. Then it comes up on our interface. It's still convenient for them. They have 7, 8 sites within Fraser Health that they can go to, and it's still done ahead of time.
One and then one.
In support of that position, one thing we're not talking about often here, but it's important, any outpatient lab work is revenue to the hospital in the region. And I think that's a great idea, Cedric, because Life Labs is making tons of money, good for them, and I don't have a problem with that. But I think if we want to support the region and everything we do, just look at the Blue Book and look at some of the revenue that comes into RCH and other hospitals. A lot of that is outpatient laboratory testing. And so we should encourage them, and for the reason that Richard said, but mostly for what Cedric said, people can go to their local hospital and have the blood work done, and then it's part of our EMR.
Yeah, just a comment on, it's one thing to decide what tests need to be done and that sort of thing, but I see fairly often consults that come through. I see the patient on the day of the surgery, and the consult is dictated, lab work not available, will be reviewed by the anesthesiologist on the day of surgery, and that's totally inappropriate. you shouldn't be dictating a consult where you have ordered blood work and the results are not in the consultation, because that means you haven't looked at them. If there's something wrong, you haven't done anything to correct it. It's a pet peeve of mine.
Okay, another day's topic. Okay, so there's one more little topic that I had, and it's just something that came out of a personal question. Oh, this is just a...
Oh.
I know, it's so bad. And I do have a few gratuitous pictures of my kids here and there. Okay, so you're seeing Mrs. C-spine intact prior to her minimally invasive shoulder surgery, but for 2 weeks from now, she's 71 years old, has rheumatoid arthritis for 15 years. She's on methotrexate and Humira, and is reasonable stable. She has a reasonable neck range of motion, no symptoms of retinoid arthritis, and no neck pain. Are you going to order a neck flexion extension view?
Yes.
No.
Yes? Yeses?
Yeah.
No's? Okay. So what would I thought? What happened now? All right.
You know.
And this came out of a pet peeve of mine that they weren't being ordered because I, again, having gone through UBC residency, was sort of inculcated in this total belief system with no one ever sharing any of the evidence with me that if I intubated someone with rheumatoid arthritis, I was going to cause them to be a quad. And so here's your atlas, your axis, the dens coming up in the middle, your Atlanta-dens interval, which is between that posterior border and the dens there. And normally in an adult, it's less than 3 millimeters, and a child less than 4.5 millimeters. Interestingly, when you look at a lot of the journals as far as neurosurgery or radiology, the more important measurement here is actually the posterior measurement, which is between the posterior border of the dens and the back of the body there, and that's where the spinal canal is. So the spinal cord is actually behind the dens there. And so you need a minimum of 14 millimeters there, because your spinal cord is about 12 millimeters, you've got about 1 millimeter of CSF and about 1 millimeter of dura. So really the more important measurement is it less than 14 millimeters, because then you're going to end up with spinal cord compression. So, and that's what happens, of course, and that's why it's the widening of that interval that's important, because what it's doing is then pushing, it's narrowing the posterior border. So some of the newer 2015 radiology literature says we shouldn't even be looking at this AI interval. We should be looking at the posterior interval on these patients with the sort of flexion extension views, because that's really what matters. So that's just kind of interesting. So basic definitions, it's excessive movement at the junction between the atlas and the axis as a result of bony or ligamentous abnormality. It's also compression, because in rheumatoid arthritis, of course, you can have pannus formation at any joint, and these are sort of joints. And so you can also have soft tissue compression or pannus formation in these areas, which also contribute to spinal cord compression. And there's actually 5 different kinds of atlantoaxial instability in rheumatoid patients. And the most common is that one that we just looked at, which is the anterior subluxation, the greater than 3 millimeters from the anterior arch of the atlas to the odontoid, or the compression of the posterior space. That's about 80%. 10 to 20% are vertical, so up and down subluxation, and that's a migration of that odontoid peg up, which is actually quite dangerous. We have what they call atlantoaxial settling, which is when that odontoid peg actually goes into the foramen magnum and settles.
Can you say that word again?
Settling.
Settling, okay.
Into the brain, which is not a good thing. So there's 5 to 10% which are lateral rotational, which is a loss of alignment of the C1 on C2, and that's much less common. Posterior is also very, very dangerous, which is where C1 moves posterior on C2, and essentially what you see on X-ray is that peg is gone. It actually breaks off the odontoid peg. And that's that one is really severe and serious. And then quite rare, but it still exists, is the subaxial. So this is below C2, so it's not actually atlantoaxial. It's actually what they call the stepladder formation of the C-spine from C2 to C7, and that's a loss of lateral alignment of each of those C-spine bodies, and can cause almost like, looks like a stepladder deformation of, and again, that's quite rare. So rheumatoid arthritis is the one that we most commonly see, but there's a whole bunch of disorders that are associated with atlantoaxial instability. We will quite often see ankylosing spondylitis, and so despite also being a difficult intubation, they can also have instability. Anyone with severe kyphoscoliosis of the C-spine actually can have instability of their atlantoaxial axis. Psoriatic arthritis, also associated, again, it's a very similar process to rheumatoid arthritis, so that's not that surprising. Down syndrome we all know of, chondroplasia, Marfan syndrome, any kind of course, destructive process of the ligaments or bones, so trauma, infection, or tumor. And neurofibromatosis, quite rare, very rare, but neurofibromatosis 1 can have some atlantoaxial instability. It's very rare though. And osteogenesis imperfecta, and then there's a whole bunch of weird and wonderful stuff that they see at Children's Hospital that hopefully we'll never see here. But Morquio is the one that's always listed. Yes?
Is the incidence for, let's say, the ones that we might see more often, like ankylosing spondylitis, psoriatic arthritis, and Down syndrome, is it as high an incidence as rheumatoid arthritis?
No, rheumatoid is the highest incidence.
By several factors, or?
Yes. Okay. So in sort of starting to look at this topic, I came up with more questions than answers, really. But these were some of the questions that I had was, how common is this? In just chatting with a couple of people in the last few weeks, the question came up, well, people are so much better treated now with rheumatoid arthritis. You know, we don't see as insanely crippling rheumatoid as commonly as we used to because of the DMARDs and biologics. Has that changed the instability or the incidence of instability in the C-spine? You know, we're just not seeing it anymore. How symptomatic is it? So when people say on the consults, well, they could move their head around and there was no numbness and tingling in the shoulders or the arms, does that matter? Are there any guidelines for us as to who should have it? And then how often should they have it? Every 5 years, every 10 years? If they need it, how often do they need it? Have there been any bad outcomes? So, you know, has anybody intubated somebody and they've become a quad from this or killed them because of atlantoaxially settling? And how should we manage these patients? And I'm going to say right up front, I didn't find the answers to a lot of these questions because the information just isn't out there, which is sort of interesting. Oh, another gratuitous. He had some questions too. Okay, so how common is it? So the data is all over the map, so the incidence really depends on the study that you read. One of the most recent studies, so I'm going to give a shout out to Brooke downstairs in the library. I don't know if any of you know Brooke in the library downstairs, but if you have a clinical question, all she needs is specific questions. I gave her about 3 specific questions relating to this topic, and she will do the lit search for you, which is awesome. Yeah. She sends you a list of like 40 articles, and then you can send her the ones that you want the full article back, and she will get you the full article, and you'd have to pay for it if you tried to get the articles online. She's amazing. Okay, so just a little shout out to Brooke. Thank you so much. So
Can I add something to that?
Yeah.
So Brooke is my second author on our British Journal of Anesthesia article that's coming out next month. And she is an amazing writer as well. So if you guys are interested in doing clinical research, you can not only get her to search your stuff, but also include her search strategy.
And she loves it, actually.
And she loves it.
Yeah.
Yeah. Definitely an underutilized resource in our
Oh my God. Okay, so one of the most recent, this is a neurosurgical journal, and looked more at the radiologic imaging of the C-spine in atlantoaxial instability. And the C-spine is involved in about 86% of patients with rheumatoid arthritis. And these are patients with actual rheumatoid arthritis. This is not your family doctor diagnosed rheumatoid arthritis. Yeah, I've got rheumatoid arthritis on no medication, no rheumatoid factors done, no rheumatology. Those are not rheumatoid arthritis, okay? Those are osteoarthritis, and people that are confused, and family doctors that are confused, okay? So these are real rheumatoid patients. So one of the things is that when we're ordering our C-spine flexion extension views, we're actually not even ordering the right tests. So when you're looking at, if you actually want to find out if someone has instability of their atlantoaxial axis, you have to order frontal neck view, lateral C-spine flexion extension, and an open mouth odontoid view. Because the position of that odontoid peg is actually really important for both the vertical and the posterior forms of atlantoaxial instability. So a lot of the criticism of anesthesiologists even ordering these tests is we're not even ordering the right tests. And then when we do order them, often they're not even of good enough quality to interpret. Okay, so that's one of the criticisms of the fact that we're ordering these tests. Any abnormality should be followed up by an MRI. And that's just because there's a lot of, this is a ligamentous instability, so we're seeing some abnormality with the bones, but it's not really showing the full picture of what's happening. So if there's an abnormality, it should be followed up by an MRI. And again, the reported prevalence, so this is just C-spine involvement, that's not at all just atlantoaxial instability. The incidence or prevalence varies widely from 3 to 60%, sort of 25% being sort of most commonly quoted for this prevalence. So it is common in rheumatoid patients to have atlantoaxial instability. It's extremely common to have any kind of C-spine involvement in their disease. Okay, so question 2, so it's common. Question 2, has the treatment of rheumatoid changed the severity? So this is an interesting article in Modern Rheumatology, 2014, and what they did was they screened 220 patients with rheumatoid arthritis, documented rheumatoid arthritis. So they looked at whether they had symptoms, what their symptoms were, and then they all went a full panel of the correct x-rays and an MRI. And they were able to then look at, and some of these people were on treatment and some were not. So they were kind of comparing the radiology to their symptoms, so looking at whether symptoms matter, and they were looking at whether people being on biologics made a difference. So they found that 42% of these patients had C-spine instability, which is actually a lower number than previously. A lot of other studies had shown even higher numbers than that. So it was a lower incidence, but there was no difference between people who were on treatment or not. So they said they couldn't really, the small study wasn't really powered properly, but they said they couldn't really say that being on treatment decreased the incidence of instability. And then interestingly, depended on the type of instability whether or not the symptoms were involved. So luckily for vertical and posterior, which are the two most severe forms of atlantoaxial instability, it was almost 100% had symptoms. So if you're missing your odontoid peg, you've got symptoms, okay? And if your peg is sort of hitting your brain occasionally, you've got symptoms. But there was very little association with just the normal, the 80% of patients that have the anterior atlantoaxial instability. There's not symptoms associated with it, generally. So, how symptomatic? So symptoms, the most early symptom is usually neck pain radiating to your occiput. And that's what the anterior. So someone has symptoms, they're going to have neck pain radiating to the occiput. And then later, after that, there can be some paresthesias, tingling, numbness in shoulders or arms. The more severe ones are symptomatic, and then the anterior is often asymptomatic. So up to 50% of patients with instability are not going to be symptomatic. So there's very little association between the severity of the instability and symptoms. So you can't really say, oh, they could move their head around, didn't have any symptoms, therefore they're not unstable. You can't really say that with anterior atlantoaxial instability. And that's been kind of shown and known for a long time. So guidelines. No, there's none. There are no guidelines. It's a very, very contentious issue in the literature. And I don't know whether it's because they need to protect themselves or whatever, but most reviews of rheumatoid arthritis from the anesthesia literature, if you look at, there's a fairly recent review in 2015 in the UK Journal of Anesthesia on rheumatoid arthritis, and again, they recommend if someone has severe disease on biologics, that they should probably have neck flexion extension used prior to surgery. If you look at most textbooks, the textbooks again will say it's contentious, but again, if they've got severe disease, if they've had the disease for a prolonged period of time, you should probably have neck flexion extension used. So just a pro-con argument here. The pros of it, asymptomatic subluxation is common. So just because they don't have symptoms doesn't say that they don't have disease or that it's not severe. There's no standard safe head position. So they've looked at things like the sniffing position in prognath, and they've shown that even prognath can cause some atlantoaxial slippage. So pillars are probably bad for patients with atlantoaxial instability, again, because it puts the chin forward, which slips the C2 back on C1 and if you're unstable. So probably the best thing to do if you're looking at it is to put the head flat on the bed in a donut. So your head's not going to move around, and it's not going to push the head forward. Okay, so that's probably, there's no safe position, but that's probably the best if it's anterior atlantoaxial instability. And again, just because they're comfortable at the beginning of surgery doesn't mean with turning, proning, or having a 2-hour surgery that they're going to be comfortable 2 hours later. The other issue is that there are incidences of stroke in patients with rheumatoid arthritis because of compromise of the vertebral arteries. So again, another thing to think about is maybe keeping the blood pressure elevated a little bit if you're worried, just to make sure that you've got perfusion to the spinal cord and you've got brain perfusion. So another pro is that x-rays can show you other predictors of difficult intubation. So it's all well and good to say, well, I'm just going to do manual inline stabilization, but that actually makes difficult airways worse. And rheumatoid arthritis often, they have difficult airways, TMJ problems, difficulty mouth opening. So if you say, well, I'm not going to get it because I'm just going to do manual inline stabilization and assume they're unstable, you may not be able to intubate them that way because that actually makes a difficult airway more difficult. So the x-rays can show you more predictors of difficult airway, and it's fairly inexpensive and easy to do. So that's the pro argument. The con argument, some studies have shown a decrease in incidence. There's no reported neurologic complications ever in an intubation from a rheumatoid patient. Radiation exposure for patients, the expense. The x-rays are sometimes limited in their usefulness. Like I said, we're not ordering all the right x-rays. And when we do, they may not be clear or show what we're looking for. And then another problem is that we're often ordering them from PACS saying review on the day of surgery. So then you see something that's abnormal. What do you do on the day of surgery? Recommendation is probably to go ask your friendly neurosurgeon, who we actually have access to here and at Eagle Ridge. And if they're not at Eagle Ridge, they're a phone call here. And to see if they need an MRI. Usually if it's less than 8 millimeters, they're not going to require surgical correction, so you wouldn't be delaying surgery for a surgical correction. And it can delay surgery. But then again, it can delay surgery if you've got an anal anesthesiologist who on the morning of surgery sees an elective rheumatoid patient and says, I was taught that you have to have flexion extension views of the neck, and I'm not going ahead with this elective surgery until I get them. So that can delay surgery.
Is there anything like a non-anal anesthesiologist?
Yes.
There's variation. Shelley, you changed.
All right, so how should we manage them? So if you're seeing someone and they're symptomatic, if they're symptomatic, they should probably see someone. So hopefully their rheumatologist is on top of that. But if they actually are symptomatic, they should probably have an MRI and see potentially a neurosurgeon, because a lot of patients end up with cervical fusions of their C-spine if they're more than 8 or 9 millimeters and symptomatic. So if they're symptomatic, they should have an MRI and see a rheumatologist. If they're asymptomatic, and this is the majority of the patients that we're seeing, there's no guidelines, but you think about things like increasing duration of disease. So if they've had rheumatoid for more than 10 years, severity of disease, you should probably order them. Again, most of the reviews and textbooks still recommend doing it. Again, the evidence is probably lacking, but there's also not a lot of evidence that we usually do a lot of damage even in known C-spine instability and trauma. We don't do a ton of, there's not a lot of case reports there either. Laura, you can correct me, you're the expert on this. But
there's been 2.
There's been 2?
In the ASA closed claims, when Don Barsdale and I did our review in anesthesia last year, there's only been 2 reported cases directly attributed to intubation in a trauma patient.
And yet we treat that seriously, right? So just because we haven't had an issue here doesn't mean that we shouldn't treat it seriously. In the Down syndrome patients, that's a totally different patient population. There have been reported cases attributable to paralysis and death, quadriplegia, death, and hemiparalysis from atlantoaxial instability. Down syndrome patients are quite different. They're more unstable. They usually have a much larger gap in their ADI. But in that patient population, there have been attributable to anesthesia and to direct laryngoscopy issues with but not in the rheumatoid population. There's never been a case report. So that was reassuring to me. But at the same time, I still don't think it's something that you can just treat lightly. Anyways, I ended up with more questions than answers, and there's just a paucity of literature out there. Yeah?
Can you repeat what you taught me the other day about the glide scope?
You know what? Who's the best person to teach you about that is Laura.
Yeah.
I think Laura, correct me if I'm wrong. Glide scope. It was so how the glide scope, where in the neck the glide scope decreases your movement, is in the sort of mid C spine, correct?
C5,
C5.
C3 to C5.
But at C1, 2, it actually doesn't decrease your movement.
Correct.
Yeah. Okay. That was what I taught you, right?
Yes, but I wanted to repeat it because it's still not completely great.
All right.
Just like this.
So a glide scope isn't going to help you here.
But it will help you in trauma.
Yes.
Often.
Unless they've got subaxial subluxation, which then it could help you. So are you going to order neck flexion extension views? And again,
Humira.
My gut feeling is that we're not the problem really, but you know, the times when at the end of the case, the aides come in and they zip the patient across with every single joint being flung around.
Yes.
It's not just intubation that's the issue, it's
but that's
the
where we
whole
go.
perioperative
Hey,
course.
stop.
I always do, but somehow they seem to still do it, so is that a common thing?
That's where anesthesia needs to take a lead role
Yeah.
with transfer of patients to
Slow, gentle. I say it every time.
So
but
what I
slow.
learned from this is that I'm probably not going to cause a quadriplegic if I intubate someone with rheumatoid arthritis. But that, yeah, it is something that we should take.
How would you intubate her?
How would I intubate her? If she's unstable?
Well, no, if she's hurt like that and there's no,
There's no
it's the day of
flexion
surgery and
extension.
there's no films, what would you do?
I would probably get films.
So you would do them.
Well, and it depends on her predictors of difficult intubation, right? If she looks like an easy intubation, that you could do true manual inline stabilization, you could do that. But a lot of these patients aren't easy, and then you do true manual inline stabilization, you take a not easy airway, and you make it more difficult, and you're probably then going to end up moving it. And am I going to cause damage? Probably not, but I'm kind of a safety first gal.
Is there an argument to be made that if they're going on the tenant table, they often also shift their head over a little bit? And that could be a problem?
Could be.
Going on Richard's theme,
I
that
would
maybe
probably
not
put
what
her
we
head in a
do,
donut
but it could be
and try not
attributed
to
to
move
us.
it, make sure she's comfortable.
But you know, on the tenant table, when they're doing the right shoulder, so the head
And
winds up
shoulder
over here.
and sitting position is the position that's been most associated with instability.
Really?
Yes.
Wow.
Yeah.
Intubate with home piece.
I get shoulder surgery.
Home piece?
Well, I mean-
Light ones? Oh, I wish light ones.
But, I mean,
All right.
we say that using a glide scope doesn't help you, but it may help you if you're using inline stabilization.
It may.
Yeah.
Yeah.
If that's what works better for you with an inline
All right, so some
stabilization.
takeaways. The big takeaway here, I need help in pack. I've got lots of projects. You want to help me?
Sure.
We better clear out because there's a bunch of people waiting.
Yes, I know. Okay, let's cut out. And that's my gratuitous child picture.
Excellent.